Hi everyone, in this video I'll be discussing drug excretion. So until now in pharmacokinetics, we have taken the example of paracetamol and we know that it was absorbed, then distributed, then metabolized. Now after metabolism, the drug has to be thrown out. So the last part is throwing the drug out, that is called drug excretion. Let us understand how do we throw the drug out. Now we know how to give the drug, that is routes of administration. Now let us understand what are the routes through which we can remove the drug out. So let us understand the drug excretion part now. Let us start the drug excretion. Now the drugs can be excreted in two important routes. The major route of elimination is called the renal route of elimination. And one more important aspect is the non-renal routes. The non-renal routes. So what are the non-renal ways? The non-renal are through the liver. From the liver, the drug is thrown through bile. From the bile, it is thrown through feces. So it will go through feces. Apart from this, the drugs can also be thrown out with the help of sweat, saliva, and tears. So one classical example for the drugs which undergo sweat, saliva, tears elimination is a drug called lithium. So a classical example is lithium, because lithium and sodium are like brothers. So wherever sodium goes, lithium also goes. And we use lithium in a condition called mania and bipolar disorder. The drugs are eliminated by liver, bile and feces, sweat, saliva and tears. And the classical example I gave is lithium. One more important thing is the drugs are also eliminated in breast milk. So I was telling you, a lactating mother is sitting in a clinic and you have to give a drug. So why we are worried? The reason why we are worried is most of the drugs are secreted in breast milk. Suppose she takes a sleeping tablet, the baby will also sleep. Why? Because the drug will go in the breast milk, the baby will also take it. So there is a risk. So the suggestion is wherever possible, try to avoid giving drugs to breastfeeding mother, that is lactating woman. But wherever possible, now I will ask you a question. In a breastfeeding mother, there are certain practical questions asked. Will you prefer giving a short-acting drug, or will you give a long-acting drug? What do you prefer? Pause the video and try to answer. Obviously, we have to give shorter acting drug so that in between she can breastfeed. Second important thing is she has to take the drug after breastfeeding the baby. Take the drug after breastfeeding the baby. So these things are precautions so that we can avoid the drug going to the baby. Now another important aspect is the drug is also eliminated by the lungs. So lungs through the exhaled air. So exhaled air, that is lungs. So what are the examples for that? Examples for that is alcohol. Sir, do you think alcohol comes in the lungs so much? No. Very minute quantity, but that minute quantity is detected by breath analyzer. And in the night time, the traffic will catch hold of the alcoholics. They measure the alcohol level by the machine called breath analyzer. But the amount coming out is very less, and you can have the smell of alcohol also. So that is one application. And again, we use anesthetics. We make the patient to take anesthetics by inhalation route. They will go to the lung and reach the brain. Again, they will come out through the lung only. So example is general anesthesia. So general anesthesia. So these are inhaled general anesthetics. Okay, so this is the example. So we understood the non-renal mechanism, the liver, sweat, saliva, tears, breast milk, and the lungs, that is exhaled air. Very classical example. Now once I understand this, let me tell you about the liver. So let us understand the liver. So it is called as hepatic clearance. So the elimination by the liver is called hepatic clearance. So hepatic clearance is given by the formula hepatic blood flow. How much is the hepatic blood flow into hepatic extraction ratio? So it is given by hepatic blood flow into hepatic extraction ratio. Okay. Sir, how to do this job? Now, if they have given in the exam, hepatic blood flow is equal to 1500 ml per minute and the hepatic extraction ratio is 0.5. What is the hepatic clearance? Let us substitute that. Hepatic blood flow is 1500 and the ratio is 0.5. So it's half. So 0.5 means half. Half of 1500 is 750 ml per minute. So it looks like GFR. So clearance is usually a GFR value. So it is 750 ml per minute. That is a hepatic clearance. It's a pharmacokinetic equation for it. Many times what happens, they may not give hepatic extraction ratio. They can give viability. So suppose if they are given the viability of a drug is 0.4, that means 40%. So 40% if you write in F, it is written as 0.4. Then can we calculate hepatic extraction ratio? Yes. Hepatic extraction ratio is equal to 1 minus F. So what is 1? The standard 100%. F is 0.4. Now hepatic extraction becomes 0.6. So if they are not providing you the HER and if they are providing only viability value, then also you can find out the formula is 1 minus F. If you minus that, F is 0.4. So you will get 0.6. That is a hepatic extraction ratio multiplied with hepatic blood flow. And I will teach you in separate video how to do pharmacokinetic calculations. Okay. In the liver, we need to understand a concept called enterohepatic recycling. Enterohepatic recycling. Sir, what do you mean by that? Now there are certain drugs which have this property. You know, recycling. Suppose you are using a plastic bottle, it is written on that it is recyclable. That means you can reuse it again. Now what happens in certain drugs? Let me draw. This is the esophagus, stomach, the intestine, and this is the liver. This is the liver. Now what happens? Let me take an example of a drug. So drug will undergo metabolism. So let us think that drug has undergone conjugation with G, glucuronide conjugation. So D for drug and G for it has undergone glucuronide conjugation. So the liver will eliminate it by bile. So this is the biliary tract through which the drug goes. So when the drug goes, it is eliminated plus drug plus glucuronide. So these will come in the feces. Now when they come in the intestine, I just enlarge that to tell you. In the intestine there are bacteria. So what happens when the drug and glucuronide come in the intestine? The bacteria can remove this glucuronide. Now you tell me what is the purpose of metabolism? To make a lipid soluble into water soluble. So that's why we add a group called glucuronide so it can be thrown out. Now it is water soluble and thrown out. Now when the bacteria in the intestine remove that glucuronide, now the drug is removed from that. Now the drug becomes lipid soluble. So again the drug can get reabsorbed back. Again the drug is reabsorbed. And again the drug enters to the circulation. Again it goes for bioavailability. So distribution, again metabolism, again excretion, that keeps on happening. So this is what we mean by enterohepatic recycling. So what happens here is the drug and glucuronide conjugation, they are going out. But when they come to the intestine, there are bacteria. The bacteria can remove that glucuronide. The drug becomes again free. That is lipid soluble. Again it will get reabsorbed back. So this again goes and produces the action. Again this cycle continues. So this is what we mean by enterohepatic recycling. Now you tell me, will this make the drug long acting or short acting? Generally, it makes the drug longer acting. So the drug becomes longer acting if it is undergoing enterohepatic recycling. Generally, there are some exception also, but generally a drug undergoing enterohepatic recycling will be longer acting. So what is the importance of knowing this? The importance of knowing this is an example of OCPs. OCPs are nothing but oral contraceptive pills. They are taken by women for preventing pregnancy or for preventing conception. Now, this will also undergo glucuronide conjugation. So, OCPs will also undergo glucuronide conjugation. Now, what happens when OCPs are taken? They will go again, they get absorbed. So, the OCPs will have the same process. So, OCPs are longer acting. Now, what is the problem? Problem is when the patient is on OCP and he takes tetracycline. Now, tetracycline are broad spectrum antimicrobials. So, when you take tetracycline, they also reach the intestine and they kill the bacteria. So, tetracycline reach the intestine and kill the bacteria. Now, what happens? You tell me, will the OCPs are longer acting or shorter acting? When I give tetracycline, they kill the bacteria, and OCPs, will they become long acting or short acting? Take a guess. Yes, they become short acting because when you kill the bacteria, they are not reabsorbed back. The enterohepatic recycling doesn't occur. Okay, so when we are adding OCPs with the tetracycline, what happens? The OCPs are now becoming shorter acting. They are shorter acting. The reason is simple, because the tetracycline kills the bacteria and the drug will not undergo enterohepatic recycling. So, what happens if they are shorter acting? The drugs will not produce the full effect. So, there is a drug failure and we call it as contraceptive failure. Contraceptive failure can happen. So, OCPs should not be used with tetracyclines. This is one of the drug interaction they can ask you in the exams. OCPs with tetracycline should not be used. Why? I will simplify the things. When you use tetracycline, they kill the microorganisms, bacteria in the intestine. That will interrupt the enterohepatic recycling of the OCPs. The OCPs are shorter acting now, and that will lead to contraceptive failure. So don't combine OCPs with tetracycline. Okay, so that is the meaning and that is the understanding of enterohepatic recycling. Now, sir, what are the drugs which undergo this? What are the examples of drugs which undergo enterohepatic recycling? The examples are, you can remember a mnemonic A topper. So, the mnemonic is A topper. What is A for? A for ampicillin. And T for another antimicrobial, tetracyclines. O for the oral contraceptive pills. P for piroxicam. And one more P for phenyl butazone. And E for erythromycin. R for rifampicin. So that is the importance of enterohepatic recycling. Let us move on to another important aspect, that is the renal elimination. Let us understand how the drugs are cleared or eliminated by kidneys. So let me call it as the renal clearance. Let me call it as renal clearance. What happens in the kidneys? Now, the unit of the kidney is nephron. Let us understand what happens exactly there. Let me draw that. This is the nephron. Yes. Now we have a blood vessel here. The afferent is the efferent arteriole. Yeah. So this is the simplest. And again, this connects to another blood vessel. They are called peritubular vessels. So they are nearby this. These are peritubular vessels. They have a connection with this. So they are connected to this blood vessel. So I'm just extending that here. Let me extend this further. This is the peritubular vessels, correct? Now, this is a simple diagram to tell you what happens in the nephron. The first step, when the drug enters the nephron is what we mean by the process called filtration. The process is filtration. So what do you mean by filtration? It is nothing but there are small gaps in this blood vessels as well as in the nephron. Now in that small gaps, the drug has to go out. Now what is the rule? If it is very small, which drugs can enter easily? The drugs which are very small in size. Now I will ask you the options now. Who can get filtered? I'll give the options for you. A small size drug or a big size drug. A free drug or a plasma protein bound drug. A lipid soluble drug or a water soluble drug. Now tell me which property of the drug makes it easily filterable. Yes, tell me. Yeah. So the filtered is the small size, the free drug. Now why not big size or plasma protein bound? If it is big in size, remember its pore is very small. So big size cannot get filtered. Proteins are very big in size, they cannot get filtered. If they are getting filtered, it means kidney is damaged. So they cannot get filtered. Now, what about lipid soluble or water soluble? Which property makes them filterable? Yes. Many are telling water soluble. No. Now remember, both lipid soluble and water soluble can get filtered because the lipid soluble, water soluble concept is only valid if there is a membrane. If there is a membrane, lipid soluble can easily cross. But this is not a membrane, it's an opening. If it is lipid soluble and small in size, it can get filtered. If it is water soluble and small in size, it can get filtered. So both lipid soluble, water soluble can get filtered. Small size can get filtered. If a drug is free, they can get filtered easily. So remember, if a drug is plasma protein bound, it cannot get filtered. So remember this point, repeatedly asked in your exam. If they are plasma protein bound, they are not filtered. If they are big in size, they are not filtered. Okay, sir. So the first step is filtration. Correct. The next thing is, what happens is, if the drug is lipid soluble, there are cells here. And I told you, lipid soluble can again go back. So these are again going back, and that process is called reabsorption. So the drugs can undergo reabsorption again. So lipid soluble drugs can again undergo reabsorption. Okay. Sir, what about the drugs which escape the filtration? The big size, the plasma protein bound drug, what happens to them? Now what happens to them? They again come to this. They again come to the peritubular vessels, the big size one, the plasma protein bound drug. You remember when we discussed plasma protein, I was telling you that if a drug is bound, it is in balance with free drug. So now bound drug is more, the bound drug becomes free drug. The bound drug becomes free drug. So there are transporters to throw them back. There is a transporter called organic acid transporter. And we have another transporter, let me take a different color. And that transporter is for basic drugs. So organic basic transporters. So organic acid transporter is for acid drugs. Basic transporter is for basic drugs. It's like Uber and Ola. It's like Uber and Ola. Acid drugs take this OAT, basic drugs take OBT. Now, is it a one-way process or two-way process? It's a two-way process. You can go from your home to office, then office to home. So the drugs can be secreted or they can be reabsorbed with these transporters. So it's a two-way process. So the drugs which have become free are thrown out again into the lumen of the nephron, and that process is called secretion. So the third process what we are dealing is called secretion. So the drugs can be secreted back. So basically we have three important processes. Number one, filtration. Number two, reabsorption. Number three, secretions. And drugs, acid drugs take their own transporter, basic drug take their own transporter. They don't exchange each other. They don't exchange. Clear, sir? Now, even the big size drug can be thrown out with the help of the transporters. The question asked in your exam is, will plasma protein binding affect secretion? Will plasma protein binding affect the drug secretion? No, because Even though it is bound, it becomes free in the peritubular vessel. So plasma protein binding will not affect the drug secretion. But what will affect if it is plasma protein bound? The filtration is affected. So drug cannot be filtered if it is bound. Very good. Fine. Now another important aspect I need to understand here is, suppose there is a poison. The drug comes in the urine. Suppose the drug poison is an aspirin poison. Now when the aspirin comes to the urine, that is kidney, the aspirin may be reabsorbed back. We don't want aspirin to get reabsorbed back. So what should I do with the urine pH so that it will not be reabsorbed back? You have a basic now. Aspirin is acidic drug. Now if you make the urine pH what? If you make the urine pH what? Then it is not reabsorbed. In aspirin drug poisoning, let me write like this. Aspirin poisoning, aspirin acidic drug, what you should do with the urine so that it is not reabsorbed? Now you have to make the urine alkaline. Why? If you make aspirin acidic drug, keep it in alkaline medium, what happens? It is ionized. Ionized means water soluble, and if it is water soluble, it will not be reabsorbed. So it will become water soluble or ionized, and if it is like this, it is not reabsorbed. It is not reabsorbed. Let me explain again. In case of aspirin poisoning, what do you want to do with the urine? You want to make the urine alkaline. What happens if you place acidic drug in alkaline medium? The drug becomes water soluble, and you know that water soluble drugs are also called as ionized, and they are not reabsorbed. So that is what we do with the urine pH. Now the question here is, how do you make the urine alkaline? To make the urine alkaline, what we use is sodium bicarbonate. So the drug used to make the urine alkaline is called sodium bicarbonate. Okay, sir. We understood. In acidic drug poisoning, we have to alkalize the urine. One more they will ask you again is phenobarbital. Phenobarbital is a barbituric acid. Phenobarbital is a barbituric acid. Again, this is a frequent asked question. Please mark it. So what do you want to do with phenobarbital poisoning urine? You have to make the urine pH alkaline. Now suppose there is one more poisoning, that is amphetamine. Amphetamine poisoning. Amphetamine is a basic drug, a weakly basic drug. Now what do you want to do with the urine? Make the urine acidic. Urine should be made acidic. Now how do I make the urine acidic? By using NH4Cl. So NH4Cl is called as ammonium chloride. It is called as ammonium chloride. So that will make the urine acidic. Are there any other option for us? Is there any other option for that? Yes, we have an acid. Can you tell the patient drink sulfuric acid, nitric acid? No, they will burn. There is one acid which can be given, and that is called vitamin C. What is the other name for vitamin C? It is also called as ascorbic acid. So we can give that. Fine. So what happens when you make the urine acidic? So basic drug in acidic medium will be ionized. That means water soluble, and it is easily going out of the kidneys. So that's the reason why the application comes again and again. So what do you want to do with amphetamine or basic drug poisoning? You have to acidify the urine. So what happens if you acidify the urine? The drug amphetamine becomes water soluble and ionized, and it is not reabsorbed, it is thrown out. So it is excreted. Yes. So this is the clinical application. They keep on asking this question again and again. Okay, sir. Fine. Sir, is there any drug which can inhibit this organic acid transport? Yes. There is a drug which inhibits this. That is inhibited by a drug called propanacid. Now, if I use propanacid with penicillin, penicillin is an acid drug. Penicillin is an acid drug. Now, what happens if I use penicillin and propanacid together? Penicillin cannot be secreted. If it is not secreted, what happens? The penicillin becomes longer acting. So when you combine propanacid penicillin, penicillin will be longer acting. Long acting. Usually if I give penicillin alone, what happens? Penicillin is thrown out by the organic acid transporter. It will be thrown out. But if I give propanacid inhibits this, and penicillin is not thrown out, it stays inside. So penicillin becomes long acting. Another important is diuretics. There is a diuretic called thiazide diuretic. They are also acid in nature. Now thiazide diuretics, and there is something called uric acid. They both compete for the same, because thiazide is also acid, uric acid is also acid. Who can take it? Whoever is stronger, they can take. So thiazide will take the transporter and it will get secreted, but uric acid cannot take it because thiazide is stronger. So what happens is there is increase in uric acid level. So thiazide adverse effect is hyperuricemia. We will understand that in the later part. So number one, they can be inhibited. Number two, there are two drugs which can compete for that. Who takes it, stronger will take it, and who doesn't takes weaker, so it will stay inside. So that will cause increase in uric acid level. So you can see all these are integrated at one place. So renal clearance, very, very important. So they will ask you the poisoning, they will ask you all these things. Okay. Right. So we are discussing the renal clearance part. Okay. We are discussing the renal clearance part. Okay. So once you understand this, can we write renal clearance is equal to who are going out of the body, filtered is going out, who is also going out, secreted is going out, minus who is not going out, reabsorbed. So renal clearance is given by filtered plus secreted, they are going out, and who is not going out, reabsorbed is not going out. So that is one thing. Now you have heard of GFR, glomerular filtration rate. So it's around 120 ml per minute. So I am taking just a value 120 ml per minute, right? Now how do I decide a drug is only secreted, or it is also reabsorbed, or it is also secreted? How do I know it? Now if you calculate the renal clearance, if a drug renal clearance is 120 ml per minute, if the value of this is 120 ml per minute, that means the drug is only filtered. It is only filtered. So if it is only filtered, it is equal to GFR. That means it is only undergoing filtered. It is not getting reabsorbed. It is not secreted. So if in the exam, if they give the clearance is 120 ml per minute, it is only filtered. If the renal clearance of the drug is more than 120 ml per minute, the value is more. That means what? That means drug is filtered. Okay, so 120 ml is coming. Along with that, some more drug is also being added, secreted. So that is filtered plus secreted. Okay, that's the point. Suppose the renal clearance of the drug is less than 120 ml per minute. That means the drug is filtered, correct? But after filtering, it is again going back, reabsorbed. So it is filtered minus reabsorbed. Suppose you are getting a salary of 1 lakh. That means you are getting 1 lakh. That is only you are getting filtered. You are getting all filtered. But if you are getting 1 lakh salary and you got a lottery of 50,000, that is secreted, your salary will be more. That means the clearance is more than 120 ml per minute. The third important aspect is you are getting the salary, but you are getting a tax deduction of 10% also. That means you are getting filtered minus reabsorbed. So that is the point, last one. Renal clearance less than 120 ml per minute. So now no problem. Let me give again the example. This is the kidney. Let me write it correctly. This is the nephron. If it is only filtered, that means it is equal to 120 ml per minute. Now if it is also getting secreted, you are adding for that. So the value is more than 120 if it is filtered plus secreted. Again, I will take an example. Now the drug is filtered. but after filtering, some of them is reabsorbed. So then the value is less than 120 when it is filtered minus reabsorbed. So this is a correlation with pharmacology and physiology. So that is about the renal clearance. Now, whenever we think of clearance, remember the drug is cleared with various points. So clearance is equal to renal clearance plus hepatic clearance plus other routes of clearance. So the total is what we mean by clearance. So clearance is not only by kidney, because we have discussed drug will go with other routes also. So the total is renal plus hepatic with other clearance also is renal clearance. Now one more application which they keep on asking you in the exam. Let me tell you, the drug can go out in two ways. Either by bile, that is liver, or by kidney, renal. So the drug may go by bile or renal. Suppose I will take an example of a drug by the name linagliptin. So linagliptin is a drug used in diabetes. Linagliptin is a drug used in diabetes. Now linagliptin will undergo bile elimination only. It undergoes bile elimination. So if the drug undergoes bile elimination, question is it safe in renal failure? Suppose the patient kidney is not working. Can we use the drug? Think and tell me. If the drug kidney is not working, can I use the drug? Yes, because the drug is not depending on the kidney to go out. It is depending on the bile. So the drug is safe in renal failure. So this is one of the commonly asked questions in exams. If the drugs are going in liver, bile, feces, can we use it in a patient who has renal failure? Yes, you can use it. Repeat last question in your exam. Yeah. So that is about drug excretion. So now we are in a position to understand pharmacokinetics. What is pharmacokinetics? Absorption, distribution, metabolism, and excretion. So we trace it again. First, we took the paracetamol orally, routes of administration. Then the drug went into the esophagus, disintegrated, dissolved. Then the drug was absorbed, and then it underwent first pass metabolism. Then it was bioavailable, went to the heart, got distributed, and we discussed something called plasma protein binding. And then we discussed volume of distribution. Then the drug went to the brain, produced action that is called pharmacodynamics, which we'll discuss later. Once the drug has done the action, it has to be thrown out, and that is by metabolism. Metabolism, I told you there are two phases, phase 1 and phase 2. Once the drug is metabolized, it has to be excreted. Either the major route is kidney or the other routes like liver, sweat, saliva, tears, breast milk, and lungs. And excretion, we discussed the enterohepatic recycling. Then we discussed the renal elimination. So the filtration, who can get filtered, small size. Then if they are free, lipid soluble, water soluble. Who cannot get filtered, big size, plasma protein bound. Then lipid soluble can again after filtration get reabsorbed. Who cannot get reabsorbed, water soluble. Suppose there is acidic poisoning. What should I do with the urine? Make it alkaline. So the drug becomes water soluble and ionized. It is not reabsorbed back, it is excreted out. So aspirin poisoning, you have to alkalize the urine. Basic drug poisoning like amphetamine, you have to acidify the urine by using ammonium chloride or vitamin C. How do you alkalize the urine? By using sodium bicarbonate. The question here is, again the drugs can be secreted back, and that is with the acid transporter or basic transporter. And will plasma protein binding affect the secretion? No, because when the plasma protein binding are there, the drugs will become free and then they are secreted out. So remember, renal clearance is equal to filtered plus secreted minus reabsorbed. So that is about drug excretion. Thank you all.